Hello friends, I am Dr. Thakur, orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFNA2 surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric on a stable time. And this is the post-operative X-ray of the same patient. And now I am going to start my surgery. The skin incision, before the skin incision, I will drop a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeter, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone owl at the correct point selected, and then I am confirming this whether this bone owl is entering at correct selected point or not in C-arm picture. So I am introducing the owl in correct position after confirming the entry point in C-arm picture, both in epi and lateral view. So this is the epi view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in epi view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both epi and lateral view. And then I will pull this bone owl for 2 centimeter to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in AP view. And now I will remove the owl. So I have removed the owl, and I'm doing reaming of the medullary canal. In the osteoporotic patient, the reaming is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFNA2 nail. So, but this is for measuring the intramedullary canal, and I am reaming by number 10 and then number 11 reamer, and the size is 11 millimeter diameter PFNA2 nail selected, and then I am reaming with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reaming this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been reamed with 15 millimeter reamer, and now I am introducing the nail of selected size, and I will hammer the reamer with the help of supine drive. I am hammering the nail inside the intramedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view, and the spiral blade can be introduced in central position in AP view, and now I am giving an incision for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur, and then I will introduce a guide wire sleeve, and a hard and a stout guide wire is being hammered in the central position of the neck of the femur, and I am confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture it is in very good place. It is central in AP view and central in lateral view also. So I am doing reaming. Some surgeons do reaming up to the lateral cortex only, but I do reaming up to the size of the nail selected. So I have reamed up to the proper distance, and now I am hammering the spiral blade. After confirming it central position in both view, and I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both anterior and lateral view, and then my assistant is attaching the arm for digital locking on the jig, and after measuring the screw size, I am introducing the drill sleeve for drilling the vortex for digital locking, and this is the 2.5 millimeter guide wire. I am introducing, just perforating making a dimple on the lateral vortex. I am hammering this hard and stout guide wire in the lateral vortex, and after confirming it in CR picture, I am drilling with the power drill both lateral and the first vortex is drilled, and now second vortex is also drilled. And now I will put a selected size of a screw for digital locking. I am measuring this on the CR. I am measuring the size of and now I am tightening the screw, digital screw. The final tightening is done. Confirming in CR picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and this is the AP view. You can see that it is in good position, and this is the lateral view of digital screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I am closing the wound. And wound has been closed. without any drain. And I will mobilize this patient on second post-operative day. This surgery is well indicated for the osteoporotic patient with an unstable type of intertrochanteric fracture because the very design of the spiral blade provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, and this is the AP view post-operative. So thank you everybody, my anesthetist, my assistant, my supporting staff. I think this is the well-executed surgery for a old osteoporotic patient for unstable type of intertrochanteric fracture. We can make this patient mobile from second post-operative day, which is very required. Although this was not a very displaced fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everybody.